Miscarriage is sadly very common, and I've had lots of messages and lots of requests from you guys to ask me to cover this subject. But the first thing I want to say is, if you are someone who's faced miscarriage or who is currently going through a miscarriage, I just want to say I'm really, really sorry for your loss and for the sorrow that you're going to be experiencing and for all of the grief that you will have as well. But I hope that some of this guidance that I'm going to share with you and some of the reasons behind miscarriage may help to bring you some comfort and may help you to understand what could be going on. So the first thing to mention is that miscarriage is something that a lot of women will experience, in particular as they get older. The majority of the time, the reason that a miscarriage happens is because of chromosomal abnormalities. So these are genetic issues that affect the embryo that don't necessarily mean there's anything wrong with you or your partner, but they're usually chance or spontaneous events that occur during embryo development and growth. What you might experience as a first or initial sign of miscarriage is some light bleeding that could potentially become heavier, and also some abdominal pain or cramps. And because women who aren't miscarrying can also experience these symptoms, which in themselves may be entirely normal, it's really difficult to know whether you are miscarrying or not without going to see your doctor. If you've had an embryo transfer, your doctor will arrange for you to have a scan around 6 to 7 weeks, what's called a transvaginal scan, to have a look and see whether your pregnancy is there and whether it's intrauterine or not. And that's really important because sometimes bleeding and abdominal cramps and pain can also signal an ectopic pregnancy. So this is where you're pregnant outside of the uterine cavity, most commonly in one of the fallopian tubes. Some other symptoms that you might experience are fairly common in early pregnancy, so things like nausea and tiredness. But other women may not experience any symptoms at all. And in fact, when they come for their first scan at 6 or 7 weeks, may not have any idea that they're in fact miscarrying. And the doctor, when they do the scan or image, will pick up that there isn't either a fetal pole or there isn't a heartbeat. It can sometimes take a couple of days or even weeks to be sure and certain of what we're seeing. And this is because sometimes when the scan is done too soon, we can't necessarily see everything that we need to. So you might need to come back after a couple of days. This is usually 7 or 10 days afterwards. Sometimes we also need to check what's called your HCG level in your blood. So this is really important because it's your pregnancy hormone, and the doctor will want to monitor and see how that pregnancy hormone is progressing. And this is particularly important if we're suspecting an ectopic pregnancy, which can become life-threatening if it ruptures inside a fallopian tube, for example. So it's really important that if your doctor asks you to come back for a repeat scan or a repeat blood test, that you do this. And once the diagnosis is made, then there are a couple of options as to how to treat miscarriage. So one option is to allow things to unfold naturally, and this is particularly so if you're already having some heavy bleeding and also some cramping. Sometimes the body is able to expel everything on its own and you won't necessarily need any further intervention. Sometimes your doctor will offer a follow-up scan or will get you to do a pregnancy test to make sure that everything has cleared out of the womb. Other times we offer management that's either medical in the form of tablets or surgical. This is where we do a D&C to try and clear everything out. There's different indications for each one, and to some extent this also depends at what stage of gestation or how far along in your pregnancy you are as to which one you can and can't have. But more often than not, you do have an option, and the doctor will discuss this with you and counsel you properly, but just know that there are several options that can be taken, and one isn't necessarily better over another. If you've had a miscarriage, because it is so common, there won't be any investigations that are done after this. It's only after 3 or more miscarriages, so what we call recurrent miscarriages, that some tests are done. Now, this is because, as I mentioned before, the majority of miscarriages are to do with chromosomal abnormalities. In fact, over 90% of the time, this is the case. But if you are experiencing something called recurrent miscarriages, which is consecutive miscarriages that can be incredibly distressing and harrowing, where you stop believing that you're actually capable of carrying a pregnancy to term, it's really important that some other tests are done in order to try and find any other less common factors that could be affecting implantation and further embryo development. Now, these could be things associated with your blood, so what we call a thrombophilia screen, which looks for weird and wonderful molecules and proteins that could affect your coagulation, so the ability of the blood to clot. And we do a general screen of this in order to try and find whether there's anything there that your doctor could then adjust or manage. So for example, sometimes things like antiphospholipids are picked up through here, or anticardiolipins, and if you test positive for that, it means that you may potentially need to take a blood thinner such as Clexane or even aspirin in order to try and help increase the risk of you being able to retain the pregnancy first and foremost, but also prevent any further complications later down the line. Then there's other things such as factor V Leiden and protein S and protein C deficiencies. These are all things which are really pretty uncommon. Also MTHFR mutations, which are more common in the population. In fact, up to 40 to 60% of people could be affected and could be carriers of this, but there aren't any strong associations with miscarriage. So sometimes with some of these results, they have to be interpreted in the context of the whole picture and your entire history. And that's when the doctor will make the decision as to which treatment or management is best for you. But these are useful tests that can be done, and they're called a thrombophilia screen. The other thing that can be done is something called karyotyping. That's on you and your partner. So this involves a blood test to check both of your chromosomes to see if you're carriers of anything specific that could be being inherited by any embryos that you produce, and hence could affect the growth and development of any embryos as well. And then there's also something called a hysteroscopy. So this is a camera test in order to have a good look around the uterus to see if there's any abnormalities there, such as polyps or fibroids or abnormal tissue or scarring that could be giving rise to miscarriage, and if there is, trying to deal with this and trying to remove it. A good ultrasound scan, in particular a 3D ultrasound, might also be able to pick this up. Some experts also check on things like your immunity, so natural killer cells, for example, and some of you might have had this done. Now, there isn't any consensus or significant evidence at the moment to point towards testing this and to advise as to whether you might need to take other things such as intralipids to help. There isn't sufficient evidence to support its use. However, there are times when your doctor might suggest the use of a steroid in terms of a tablet form, and this is in particular useful for women who might have autoimmune conditions that could also make them a little bit more prone to recurrent miscarriage because of the effect that they could have on your general immunity. So always discuss this with your doctor first before you decide to take anything like that. Lots of women believe that taking progesterone supplements could help to reduce their risk of miscarriage. And certainly, with women who've got short cycles, menstrual cycles, what we call a short luteal phase, there may be some evidence for this. But with the majority of women, there isn't enough evidence. If you do have IVF, you will always get progesterone supplementation. And if you have a natural pregnancy, you will make your own what we call endogenous progesterone. Taking any supplements in addition to that should always be done with your doctor and by asking them first. There's a small subgroup of women with recurrent miscarriage for whom it may be beneficial. And as I say, women who may have shorter luteal phases, but always counsel with your doctor and discuss this with them before you start to undertake any such treatment. So what else can we do to try and help women who face recurrent miscarriage? If all of your blood results come back as normal, then the chance of you having another miscarriage is in fact very low. However, this is very difficult to believe, especially if you face lots of miscarriages. It can make you very anxious about the future. Having IVF in itself doesn't help reduce this risk. But what you could consider doing if you are having IVF is something called pre-genetic screening. So this is where the embryos that you produce are screened to see if they're genetically normal or not. This isn't necessarily 100% accurate because we're dealing with embryos which are very young, in the very early stages of development. There is the potential to also get an incorrect result, but it has been shown to give useful results, in particular for women who do face recurrent miscarriage and who would prefer to screen the embryos before they have an implantation to give them that added level of reassurance. So it's something, again, you can discuss with your doctor to see if you're an appropriate candidate for that.